So if you joined last week and now again, you would have heard a little bit about what is trans and gender identity. You would have had an overview on hormones, a bit of informed consent aspects. And now we're going to look much more what is our job as mental health care providers, being it social workers, being it nurses, being it psychologists or counselors, and how we can contribute to this field. Now I'm trying to move the slides and they don't want to move. Let me just quickly see if I can stop share and share once again. Just give me. There we go. So what was interesting is that if you look at the history of especially your psychology and psychiatry, there was historically a very strong element of trans and gender diverse people seen as a mental illness. Now, if we go further back in history, we also know that especially in Western perspectives, there was components of spiritual or religious query about a person's gender identity. But even if we want to go and look at some of our mainline religions currently, for example, Christianity, you do see elements of gender diversity even in the Bible being described there. However, in some of our other communities, if we think, for example, at our First Nation or our indigenous people, I think South America would use Native people, you would see in some of those cultures, it was revered if you are two-spirited or your gender identity is diverse. And there's even some elements in our African perspective and cultures, but that I will leave for another day. However, after this kind of religious ideas around it, it moved much more to then, this is a mental health challenge or problem, or even up to the point then that it became a diagnosis. And with this mental illness aspect or pathology, psychopathology, came the whole thing of becoming the other. So if we look, we're going to look at the DSM, we're also going to touch on the ICD, and then we're going to look at depathologization. So in the DSM, in DSM 1 and 2, there was a term used, sexual deviation and transvestism. And that was a whole moral behavioral deviation. So it was a pathologized identity. DSM-3 started having this new idea that sexuality and gender are two different things. So we see in 1973 that homosexuality or gay and lesbian was not seen as a pathology anymore. However, gender diversity or gender incongruence was still seen as pathology, and then it was identified as transsexualism or gender identity disorder. It was a psychiatric disorder, and it started becoming quite a gatekeeping for care. We moved into DSM-4, and we still have gender identity disorder, but there was a movement now that it was the psychological distress to this identity. So it was not as such the identity that was pathology now, but related to the distress. So still pathologization, but we see that shift. And then in DSM-5, there was a lot of debates going on. Should we leave it in the DSM or not? And we know that DSM is predominantly America. And we see there that it moves to gender dysphoria. And then it is the focus on the distress and not the identity at all. So kind of a destigmatization. However, there is still that uncomfortability of you have to be dysphoric. And we know that not all trans and gender diverse people do experience dysphoria. This has now moved to DSM-5-TR, and we see a recognition of spectrum identities, and there's affirming rights-based framing. But still, I mean, if you're in the DSM, it is still under mental health. So we went from the idea of transvestitism, that was the first word, to transvestism, and then up to now, we have gender dysphoria. Still a mental disorder, and it basically says a marked incongruence between one's experience, expressed gender, and assigned gender. We're already seeing statements coming out from the professionals, the expression of gender characteristics, including identities that are not stereotypically associated with one's assigned sex at birth, is a common and culturally diverse human phenomena that should not be judged as inherently pathological or negative. And this was quite interesting because it was also in that time that we see that WHO started looking at the ICD, and there was all these engagement internationally. We had a conference here in South Africa from Gender Dynamics, and there was a discussion around this: should it be depathologized? And we had people from the continent here, and some people really spoke up about they want to be pathologized because in their context, in order to access healthcare, they have to have a diagnosis, and they have to be seen as mentally ill and being treated for this mental illness. Where from a rights-based, a human rights-based perspective, as well as how we now understand gender and identity as a diversity on a spectrum, we start realizing that for us in South Africa, depathologization stands out as the way to go. So, with the international classification of diseases, and that is for WHO, the World Health Organization, we know this is a global standard for classifying diseases and health conditions used by health professionals, researchers, and governments worldwide. And it's for clinical diagnosis and treatment, health statistics and reporting, insurance and billing systems. You know, in South Africa we use it, and public health surveillance and research. So currently we have the ICD-11. It was adopted by WHO, the World Health Assembly, in 2019, and it came into effect in January 2022. So it reflects WHO's commitment to human rights-based, non-pathologizing approach to gender diversity and sexual health. But let's look a little bit at that history as well. So when we look at the ICD-10, so that was in 1990, it came out. It had trans identities were classified under mental and behavioral disorders, as gender identity disorder, and as transsexualism over the years. This framing pathologized trans identities, treating them as a mental illness that required diagnosis for medical intervention. However, the ICD-11 is very different. It sees it as a trans-related categories were moved out of mental disorders and reclassified under conditions related to sexual health. And the new term that we now use is gender incongruence, defined as a marked and persistent incongruence between a person's experienced gender and assigned sex. And I think this is very important, is to also realize it does not speak about a person whose gender identity was at a stage maybe female and now it is male. So it doesn't say that to transition is going from one side of the spectrum to the other, but it is to align a person's body to reflect their inherent gender identity. That is the one aspect here. So it is what they were assigned at birth that is not fitting them, their gender identity, but also it doesn't speak about one side or other side. So a kind of a binary system, but any person that has an incongruence. So it could be a person that is non-binary or gender diverse, could even be bi gender, and we know there's many other genders out there. So there's a shift from a depathologizing of trans identities, recognizing gender diversity as part of the human experience, not a disorder, while keeping a category that allows access to care and legal protections. So, in South Africa, we don't have implemented the ICD-11 yet, but it's definitely on the cards, and people are working in Department of Health on it, on this change towards ICD-11, as well as we're going to see it in private healthcare. There is also the side that some of us had the fortunate experience of being part of the guideline development process. And this process has been for the last 2-3 years in the pipeline, where we looked at hormones, access to hormones. We looked at the rights-based aspect of gender diversity and trans identities. We looked at gender-based violence and SGBV as well. And this guideline, and mental health. And this guideline will be released around about next year, February, March. So we're in the final phases just before release. I am not going to stand too long focusing on what is gender incongruence in the ICD-11. You are more than welcome to come back to these slides that's going to be shared with you, or you are welcome to go and read the ICD-11 just to know what it is currently in the end if you want to work with this diagnosis. The gender incongruence in childhood was, though, a very contentious issue. I think it's still very contentious. We know also in different spheres, we have that people see it as different. And some people also say, but why do we want to already diagnose from an early age in childhood? Shouldn't we look at a bit later, only for adolescence and that kind of age? So this is still in the ICD-11, but definitely a lot of discussions around that. Now, why is it important for us to be part of an MDT? And we have heard that we're not always needed, and there is not a psychological assessment needed in order to access hormones. We know at this stage there is still a requirement that if you want to access surgery, that you need a report. But for trans individuals living in a world that is not accepting and not welcoming, that has an impact on their mental health. And I'm going to refer us back to Alex Miller's study that looked at 9 countries in Southern Africa and East Africa. We had 832 participants from South Africa, and of those, 232 were trans and gender diverse. So this research focused on sexuality diversity as well as gender diversity. And what we found was the realities of our trans and gender diverse people were that 63% experienced depression, 39% had a diagnosis of anxiety, suicidal ideation or suicidality in the past year was 36%, with suicide attempts in the past year 16%. So that was 2018. And I think this is quite significant to realize. So if we're looking at cisgender women, that would be cisgender women with a sexuality diversity. So most likely our lesbian or bisexual people. And we see there suicide attempts. Lifetime was 36%, in the last year 7%. If we go to trans women, the lifetime is 43%, last year 14%, trans men 41%, and 29%, I think. Sorry, that was an unfortunate thing that went over there. And then for our gender non-conforming individuals, we had a 54% lifetime and 17% in the last year. When we look at alcohol use, so hazardous, harmful, and dependence, we see nearly 46% of our trans and gender diverse people had challenges in that. Drug use, harmful, and dependence, nearly 25%, and smoking every day, 32%. Now, I query the word using other challenges, because the moment we start using other challenges, it could indicate that we say that trans and gender diversity is a challenge. And we know that is not a challenge. That is a given. That's your known identity. However, our trans community also experience anxiety, depression, bipolar, conduct disorder, substance abuse, autism spectrum. We know there is quite a lot of research currently in that area, because it really is indicated that we have a higher percentage of trans people being on the autism spectrum, dissociative identity disorder, borderline and other personality disorders, sexual disorders, and disorders of sex development. So all of those are there. But I think the two that really is significant is anxiety and depression, and then the new one, autism spectrum or neurodiversity. Now, when we start asking about why do we see such a high percentage of people having anxiety and stress-related anxiety, then and depression, then we need to go and look at the idea of minority stress. And this is coming from Myers' work, where we know that if you experience gender-related discrimination, gender-related rejection, victimization, and non-affirmation of your gender identity, the possibility that this will lead to minority stress is very high. And this is our distal factors, so the factors coming from outside. However, we also know there's proximal stress factors, so that internalized transphobia that a lot of our trans people experience, negative expectations about how people are going to treat you. So, for example, as a trans person, you're going to fly, but your gender identity on your identity document does not reflect how you look. That expectation of, oh my word, what's going to happen next? Will people look at me? Am I going to get on the flight? That kind of negative expectation already ready for what's going to happen, that kind of hypervigilance. And then concealment, trying to not be visible. And we see that especially when a person goes into their transitioning phase physically. Quite often you see that very strong discomfort coming through. Some will conceal in the beginning, trying to still fit into this society, but then also the risk factors that might be there in the community if they look different than the community knows them. And it's all these factors that we need to also explore with clients as they go into transition and while they're transitioning. So all these aspects then leads to minority stress. However, there's also resilience factors. And having that kind of community connectedness, affirmation, people that's there, that safe space, as well as pride, also then has an impact on a person's Outcome being it mental, being it physical health. So we know that experiences of discrimination acts as a stressor, and it can have emotional and physiological response, as we saw. If it is frequently over time, biological systems undergo strain and the individual experiences increase the risk of a poor physical and mental health outcome. The second and alternative way minority stress impact health is through affecting health behavior. So we see in South Africa that people will not go, for example, to the clinic because they are so used to what happened in these clinics. And we're going to touch on it a bit later. Also, what happens and how many people have experienced in clinics harm through staff's behavior. And this again has an impact on health behavior. So a person may have a HIV positive status, but due to them knowing what's going to happen at the clinic, they don't access their ARVs. So stigma and discrimination impacts mental health, physical health, access to care, and access to competent care. And this leads to health disparities in inequities. So what is then my role? And here I'm going to look at the psychologists as such, but also many of us as social workers and people also working in this field, even our OTs, our speech therapists, our counselors, our nursing staff, can also find themselves in these. So one of the roles, and this comes from our HIV Clinician Society Gender Affirming Healthcare Guidelines, one of our roles is to understand the complexity of assessment, or spoke about the whole idea of people going to spaces and then they get being gate kept from, let's say, receiving hormones and gender affirming healthcare. There's a story of a psychiatrist in South Africa that when people would arrive, a trans woman would arrive at this person, his doorstep, he would ask the trans woman to hold a doll. If the trans woman was able to hold this baby doll like a cisgender woman presumably would hold this doll, then she would be seen as trans enough to access care. However, if she didn't know how to hold this doll in a cradling position, ready to breastfeed the doll, then she was not a trans woman. Evaluated in order to access care. And that is why we move now to a gender-affirming medical intervention. However, when we come to youth, we work completely different. And there we work in a multidisciplinary team, and there's much more walking alongside this team with our clients and finding the way forward. But what do we then assess in the end? Well, we definitely can aid in diagnosis, not of gender dysphoria or gender identity disorder, or as we see in the ICD-11 gender incongruence, but not that diagnosis, but definitely if the person has depression, anxiety, bipolar, personality disorders, etc. And also to help them there if they need to access then a psychiatric intervention. We can also provide support. And I think this is where it's unfortunately in South Africa that not all our trans and gender diverse people will have access to mental health care providers, because definitely to walk alongside a person as they transition, for myself as a psychologist, it is an amazing space to be in, to see how this person become who they are already, but also externally, and how they experience that freedom. But also they do go through challenges, how to navigate the world, because most of us that are trans are socialized in a other gender identity than who we really are. And how do we then navigate, for myself, for example, the world of a man? How do I navigate those spaces? We also know that we can provide support to the family, the partner, and everybody part of this journey. Some of our trans people also do engage in psychotherapy and can also provide documentation. Once again, you heard that Madeleine spoke about the gender marker that can change, and we can definitely provide the second letter that go to Home Affairs. And if you want to, you will see right at the back, one of our appendices, look at a letter that you can write for your client. But we also provide documentation for our people that want to access surgery. And over the years, also support groups. We have found this health groups is much more a participatory space. So people that have been journeying for quite a while. We also know that, oh, I see I stopped sharing. I wonder why it's doing that. We rush right through down. Apologies for that. It is an interesting evening. And then our clients. And we see that that is quite important because intrinsically working in the field of healthcare, we do have certain powers. And to use our power in the service of our clients becomes very important. Being it that you work in the healthcare systems, opening doors for your clients, being it in other areas, but it is very important to advocate for our clients. I'm going to quickly touch also on another guideline that's available, and that is the practice guideline for psychology professionals working with sexually and gender diverse people. And the first